Well, good afternoon. I have the unenviable time slot of being the last presentation of what looks like a very packed agenda you've had today. So I will try to keep your interest through my slides. I'm Mary Beth Musumeci. I'm an Associate Director at the Kaiser Commission on Medicaid and the Uninsured. For those of you who don't know, we are a nonpartisan, independent foundation. We do research and analysis in policy areas affecting people who are uninsured and vulnerable populations. So I am going to talk with you about Medicaid's role in financing children's behavioral health. And as you can see from this slide, Medicaid finances over a quarter of behavioral health spending. The data are old, but unfortunately 2005 is the most recent available. Medicaid is, in fact, the single largest behavioral health funding source. And then you can see, by comparison with the second pie, that Medicaid is funding a larger percentage of behavioral health spending than all health spending. In terms of the services that children who receive Medicaid are using in the behavioral health area, it's about 10% of children are using behavioral health services and or psychotropic medication, and you can see the breakout at the top of the pie. There are an estimated 20% of children in the U.S. who need behavioral health services, and so the 10% of Medicaid children beneficiaries suggests that there's underutilization or unmet need, and particularly with the information that leads us to believe that children in low socioeconomic groups may have a higher need for behavioral health services. But that's where we are. And then among those children who are receiving behavioral health services, these are the most frequent services that they're using. So you can see that's led by outpatient treatment, psychotropic medication, screening, assessment, and evaluation are the top three. So I'm going to shift gears a little bit now and talk about how you become eligible for Medicaid as a child. And there are two basic ways. So there are a group of coverage groups based on income, and then there are coverage groups that take disability into account. And so the ACA required states to expand Medicaid to all children to 138% of poverty as of January of this year. This is different than the Medicaid expansion for childless adults that states are debating. Some states continue to debate. You hear a lot about in the news now. So this was not optional was not part of the Supreme Court's decision. And so all children up to 138% of poverty must be covered in their state's Medicaid programs as of now. In some states, that meant that children moved from their CHIP program to the Medicaid program. And the reason that income-based coverage is important is that even though these children are eligible just based solely on their family's income, about 2/3 of children who are using Medicaid mental health services actually qualify just based on household income alone without looking at their own disability status. The second way is through a disability-related coverage group, and this is a way for children who have a significant physical or mental health condition to become eligible at relatively higher incomes. These categories pre-existed the ACA, and they continue. So, for example, children who receive SSI, children who otherwise would require an institutional level of care. And to give you an idea on the mental health side, as of 2012, 8.5% of children who were receiving SSI qualified for benefits based on a mental health diagnosis. And in most states, that means that they automatically are also eligible for Medicaid. The other important thing to note about children's Medicaid eligibility is that the ACA has a maintenance of effort requirement that is in effect for children through the end of September 2019. And what that means is that states cannot make any changes to their eligibility enrollment policies as they apply to children until after September 2019. So the policies that were in place at the time of the ACA's enactment in March of 2010 continue through then. So now turning to benefits, This chart shows you, I've broken it out into acute and long-term care, and then across the top, mandatory and state option. So you may be familiar with state Medicaid programs. There's a set of mandatory services that if you're going to participate in Medicaid, you have to offer. And then there's another set of services that states can pick and choose from and opt to offer. And so I've bolded the things where we often see behavioral health services falling. So the idea behind Medicaid is you need to fit whatever service you're seeking for a child into one of these categories of covered services. So inpatient, outpatient hospital, physician and other practitioner services, EPSDT for children, I'm going to say a bit more about on the next slide. And then on the optional side, of course, pharmacy, clinic services, the other diagnostic, screening, preventative, and rehabilitative services I'm also going to say a bit more about because that's where we see a lot of behavioral health services being funded. Inpatient psychiatric services are only covered by Medicaid for people under age 21 or over 65 at state option, so not for adults. And then case management, some home and community-based services, and then two things that were added and expanded by the ACA, Section 1959, health homes, which I'll also say a little bit more about. So first, EPSDT. It's the Early Periodic Screening, Diagnostic, and Treatment Services benefit. It makes Medicaid an extremely rich benefit package for children. If you remember from the prior slide, EPSDT is one of the mandatory services. So all states have to offer EPSDT to kids. And for Medicaid purposes, you're a child up to age 21 for EPSDT. So it's birth to 21. The screening part requires medical, vision, hearing, and dental screening at predetermined intervals and also whenever a problem is suspected. And then the treatment part of the benefit, and this is from the federal statute, includes any services necessary to correct or ameliorate physical and mental health conditions, regardless of whether such services are covered in the state program for adults. So the beauty of this is, remember from the prior slide, I divided things into mandatory and optional. States can pick and choose for their adults, but anything on that chart is fair game for kids. And so kids have to have access to all the optional services, even if the state does not offer them to adults, and that makes the benefits package quite rich. I also wanted to say a bit about the rehab option, which is one of those optional services. It's not necessarily limited to behavioral health, but this is where we see a lot of states funding their behavioral health services. I should have said on this slide, this is not limited to children. This is all beneficiaries. But you can see that of beneficiaries who are using services under the rehab option, the vast majority have a reported mental health diagnosis, and that's true for enrollment and spending. So what types of services are states providing under the rehab option? And you can see here it's a lot of the things that we think of as the traditional behavioral health services, individual and group therapy, crisis intervention, medication management. One of the things that is appealing about using this as a funding source for services in behavioral health is that these services can be provided at home or in the community. They also can be provided in other settings, and so that's where we start to see things like supported employment services funded here. Section 1915I is the Home and Community-Based Services State Plan option. This is an option that was available to states back from the Deficit Reduction Act of 2005, and we saw a handful of states implement it, and the ACA amended it, hopefully to entice some more states to implement it. And basically, it allows states to offer home and community-based services through a state plan, their state plan benefits package, instead of through a waiver. So you may be familiar with 1915C, home and community-based services waivers, which are a very rich source of benefits for people with disabilities, particularly for long-term services and supports, but they also can have enrollment caps and waiting lists. If you offer benefit through a state plan, you have to offer it to everyone who qualifies. Financial eligibility is up to 150% of poverty, and then the ACA added a state option to cover people with incomes up to 300% of the SSI rate, which is, as you can see, significantly higher. The other thing that's unique about 1915I, as distinct from services under a waiver, is you don't need to meet an institutional level of care. So home and community-based services can be offered more as preventive care. The state has to establish some needs-based criteria, but they have to be less stringent than what they require for institutional services. As I mentioned, you can't cap enrollment. If the state takes up this option, they have to offer it to everyone in the state, but they can pick and choose, design the benefits package to target to different populations. So state could put together a behavioral health services package. And you can see the services listed. They're the same services that are available to states as under the waivers, and that was another change. The ACA aligned the two services lists, so everything that states could do through a waiver is now available under 1915I. And in preparing for this presentation, I was able to find one state, Montana, who's listed as using 1915I targeted to children and youth with significant mental health conditions. So if this is something that interests you, I suggest you take a further look at Montana. The last ACA change is the Medicaid Health Homes state plan option. And this is a new authority for states to create health homes actually for children or adults, but I have 3 states here as of last spring: Missouri, New York, and Ohio, identified as using health homes targeted to children and youth with serious and persistent mental health conditions. And so the idea is to provide care management and coordination services for these populations. And states can target their health homes to beneficiaries with at least 2 chronic conditions, 1 chronic condition and the risk of developing another, or 1 serious and persistent mental health condition. And you can see there's mental health, substance use, as well as some physical health conditions listed in the statute. One of the enticing things for states here is that there's 90% enhanced federal funding for the first 2 years that the state is providing health home services. And you can see the list of services that states are offering. As I said, it's a lot of care management, coordination, working on smoothing out and improving transitions between settings. I also wanted to touch on another change by the Affordable Care Act in the area of mental health, and that involves mental health parity. So we've been talking so far about state plan benefits. States have another option. They can instead offer something that's called an alternative benefit plan to their beneficiaries. This used to be called benchmark benefits. This was added by also the Deficit Reduction Act of 2005. And we didn't see a lot of states taking up this option. Basically, it allows states to design a set of covered services that's based on one of 3 specified commercial insurance plans or something that's determined appropriate by the Secretary. We're going to see more states doing this because the ACA mandates that states provide alternative benefit coverage to the newly eligible adults, and states continue to have the option to provide it to other populations. They also can design their benefits package under the ABP authority targeted to different subpopulations. Another thing to note is how mental health parity comes into this is that unlike the Medicaid state plan benefits package, the ACA provides that the ABPs have to provide parity between physical and mental health services. The ABPs also have to ensure EPSDT to children. And finally, I wanted to highlight for you a recent demonstration that CMS did with some states focused on psychiatric residential treatment facilities. And so this was focused on determining the effectiveness of community-based services for children who were in or at risk of entering these facilities. And you can see the states that participated there. So the demonstrations offered sort of your traditional services like individual and group therapy, but they also sought to test a number of what they called non-traditional services, such as wraparound intensive care coordination, peer support, intensive in-home services, respite, mobile crisis, and flexible funds. So, for example, the use of one-time funds to pay to set up housing if transitioning from an institution to the community. And the results from that demonstration showed that the home and community-based services cost about 25% of the cost of institutional care, with an average savings of $40,000 per year per child. And they also found improvements in a number of other areas, including education, behavioral and emotional strengths, outcomes, stability of living, caregivers' ability to go to work, and then also decrease in suicide attempts and law enforcement contacts. And I should also say I have a web link on each of the slides, so if you're interested about any additional information about any of these programs, you can get more information, and I think I will stop there.